Thank you, Lori. Just to recap briefly what we heard from our panelists, we heard from Jim about the concerns of educators, the strength of the school breakfast program, and the importance of school employee wellness programs. And then we heard from Norris about a number of initiatives currently underway in the U.S. Department of Education. And then Lori, of course, just shared with us her research in children living in adverse circumstances resulting in dysregulation, and then the very positive impacts of the parent core intervention. So with that just brief synopsis, I want to ask the panelists if they have any comments, observations, or questions before we turn it over to the roundtable. They may not, but I thought I'd ask them anyway.
I just want to make a comment that I was fascinated to see that your intervention could show an impact on obesity, which we're so concerned about, without any content related to obesity. And for an educator and somebody who tries to do behavior change all the time, where you think you have to teach somebody to like broccoli, that just working on some of the underlying factors and they automatically have a measurable difference is fascinating.
Thanks, Jim. I do have one question. So with all that we heard about the concerns and what educators are dealing with, what parents deal with, the many priorities and many programs underway, do you all have any thoughts in terms of what the health sector could do more efficiently, or things that we might undertake to better work with education, to better work with schools, educators? I mean, we know that, as I had indicated earlier, we know we both speak in very different languages, and so we've worked with a number of partners, including the National Association of State Boards of Education, to, create guidance that helps health departments work with schools and understand the culture and how they work. But, with that said, it's still not very easy.
Yeah, I would argue, it's important to realize that many of the things we've discussed, from vision screening to asthma management, are a matter of state law. So, for example, one of my colleagues in the last month spoke at the gathering of all the optometrists in America, and we were looking at their legislative agenda, and they talked about how only 33 states require vision screening, and that was on their legislative agenda. And I know the allergy specialists were very involved in the passage of state laws on emergency response to anaphylactic shock and things like that. So I think it's important, a lot of these things we identified, asthma, vision screening, to some degree they're a matter of state law, and so activism on the part of physician specialists are very, very critical. And then finally, I would add, with your new guide on how to make the case that health contributes to positive academic achievement, that's a case often best made by those from the scientific medical angle, so they can help make the case that these investments matter and will yield results in academic achievement.
Thanks, Norris. Lori, did you have a question you want?
I was going to make a comment.
Yes, please do.
I think, I certainly don't have the answer, but I think that there are some incredible opportunities. One in terms of early childhood, and I think that the science and the way that the messaging has gone has really brought the attention of everyone important to the federal government, philanthropy, the business community. I think people are really rallied around this cry of investing in the early years. I think it can be very limited, and it certainly shouldn't be limited to 0 to 3. But I think the energy and the momentum is there. And so that's one place where I think that the different sectors can really come together, because I think new things are going to be created at this time. And so instead of trying to undo something that's already done, to create something that's new that really is cross systems. The other place that I think there's really opportunity is in the area of special education. And the one thing that so we are working very hard on an application to the U.S. Department of Education for their I3 Investing in Innovation initiative. And after, I think this is the 4th or 5th year of that, which is a pretty large investment in education opportunities that have an evidence base, there is a category, a priority category for students with disabilities. And the overlap between dysregulated behavior, ADHD, many of the things that we've been talking about in some of these talks are really what's accounting for a large proportion of the special education dollars. They don't come into play until the kids are already in 3rd grade, 4th grade, 5th grade. So by our measures, we think in an urban environment with all these stressors, about 25% of kids are showing these kind of problems when they're coming to school on the first day of kindergarten or even pre-K. And so really trying to pull together from an advocacy perspective, but also integrating across different sectors, how we can focus on this very high-risk population.
Thank you. Question? Is it Martha? I'm sorry. Oh, Pamela.
So I was fascinated with your public health approach to education, Jim. I wasn't expecting to hear you say it that way. And I know a lot of public health departments have and other organizations have tried to work with school districts. So they go to the school district or they go to parent organizations. But I haven't heard of anyone going to an affiliate. So, like, how do you connect them? How do you find them?
Give me a call. It's I mean the way we do it is you have to have the established relationship and trust with them. Doing it on a one-by-one basis, just the same as if you were going to go in and try to convince. I mean, if you're an investigator and you're trying to do an intervention in middle school, you got to go to the principal. He or she is not going to say yes on the first meeting. I mean, you have to establish a relationship over time, really listen to what they're dealing with and what's important to them, and connect what you need to do with what they need to. I mean, all of these trust building things. But they are there. The people in NEA care about health. I don't have a problem trying to convince teachers or their affiliates that health is connected to educational achievement. They're just looking for, okay, show me the way we can do it that I can fit into what I already do and with the resources I already got, and it's going to make an impact that I can see. I don't know if that helps.
It's similar to what we had a session on. I'll call it health and all policy for now, but it was that same situation. You can't go in with your agenda. You need to find the mutual win-wins. But I just meant, is there a directory? I mean, how do you find them?
There isn't a public directory, because I'll tell you, working inside of NEA to find out the name of the local that's associated with one school takes a little bit of work for me. So it's not like we have a phone book online. But there is the information about state affiliates is accessible. It's public on the NEA website, and they are usually the best way to go and find out, okay, who's in Montgomery County, Maryland, or what's the name of the president for Anne Arundel County, or that sort of thing.
Thanks, Jim. Questions? Martha?
This goes to Lori Brotman. Thank you all for your very good presentations, but I'm really curious about the parent core in terms of the intensity of the time asked of parents, the kinds of professionals who are involved in the program, just to at least give us a sense of that. And also, I know you've done this in a sort of research paradigm, so it's obviously more expensive, but I'm kind of curious about what your sort of gestalt of the per capita costs of implementing these kinds of things would be.
So the parent program it's now 14 sessions. So they're 14 two-hour sessions. And in our last trial, as I said, 60% of the parents came to any session, so at least one session. 40% came to 5 or more. And if they came to 5 or more, the average attendance was 10 sessions. And so we know that we need, at a population level, we need to get their attendance to be at that level so that we can have this kind of impact. And so part of our work outside of the trials over the last really 6 or 7 years has been to figure out how to market the program to parents, how schools can do that, how teachers can do that. And it's a buildup over, we have a 2-year model for helping schools to build capacity for the program. In the trial, it was a combination of mental health professionals from the school and teachers delivering the program in the early evening, along with our staff, mental health, mostly psychologists, social workers, running the program. We're now fully training schools to do it on their own with technical support from us. In the trial, what was interesting and I think surprising to us and a lot of people is that 80% of the pre-K teachers were participating in this after-school program, and after-school meaning 5 to 7 in the evening. So they were paid hourly rates to do that, but at first people said, oh, they won't be interested in doing that or committed to doing that. It's a long day, and it is a long day, and so we have to make it valuable for them to participate. But part of the reason that we are getting bigger effects over time with the teachers, I think, is because they're participating in the program. And so they get a lot out of that piece. And it's an important piece for the parents to also have that extra time to interact with the teachers. The cost of the program. So we are currently working on and hope to finalize within the next few months cost-benefit analysis in terms of quality of life years and also impact, return on investment to society from our trial findings. And so because we have such a range of outcomes, we're looking across domains and trying to look at the literature to say, how does that all sort of tie together? So we're looking at high school graduation, special education outcomes, juvenile justice outcomes because of our impact on serious behavior problems, and then also physical health. And so I don't have that yet, but our preliminary analysis clearly shows that we're in a very good range for the program, for the population, in terms of cost savings. The cost of the program, once it's in place, so once we spend a lot of time building relationships, working with principals, training the teachers, training the mental health professionals, coaching them, which is in the education world, it's very clear that you need to do serious on-site coaching with teachers to get them to adopt new practices. Once we do that, the cost of the program for families, counting the whole population in the school, is closing in at like $500 a family, which is nothing. And so we're trying to, we're working on the capacity building piece and trying to do that so that they can implement with fidelity for as little cost as possible. So we're working on things like e-learning for some basic knowledge, but there's always going to be a need for coming together and on-site coaching. Thank you.
Thanks very much. Very interesting.
Thank you.
Robert?
George? Okay. So this is actually a comment and maybe a question for Norris. You made this comment that medical specialists and subspecialists are delighted to come to schools to give screening tests. I guess my reaction to that is, watch out, because that several decades of experience with the United States Preventive Services Task Force has taught us that when you look at the evidence, it isn't necessarily always a good idea to go out and screen for things, particularly when there's a pecuniary interest on the people that are doing the screening without necessarily a clear benefit. And I was thinking that maybe this is something that the roundtable could be very helpful in, that trying to figure out when you want to go toward that more clinical model, and under what circumstances you might want to try to use your resources actually to get away from the clinical model. That's a lot of what we've been talking about today. I don't know how you react to that. But.
Well, I didn't mean to imply that everyone should, go off to screen. I was simply saying that sometimes these are a matter of state law. And of course, you could argue the optometrists have a vested interest in that happening. But it's also something, we've discussed here that's critical. So, the same with asthma and asthma management in schools, and, what are the parameters for who can help a child in anaphylactic shock. I mean, that's all played out at the state level. Of course, CDC, with our input, produced a guide on that and how to do that well. But, I wasn't, you've raised an important issue that I think you guys should consider to chew on it.
Yeah, because, and again, I think that the issue is that there are opportunity costs, particularly when you get these services that are mandated by states. The school districts don't have much wiggle room, so that the consequence of doing these tests and actually dealing with the kids is that you're siphoning money right off the top of the school district's budget that they might have used elsewhere. So when you do that, it just seems like some careful evidence-based review is really going to be crucial.
Points well taken.
I have a related question, but not quite that focused. So in the last panel, we heard Charles Bash talk about the 7 priorities. I asked him this question over the break, and I asked him basically, in what did they do to develop those 7 priorities, and then how generally applicable were they across all school districts in all states, and urban and rural and so forth. And he's probably better to respond to it than I. Maybe we'll give him a chance to do that. But I think the gist of his response was that that to some degree, schools ought to be looking at this and tailoring it to the situations. I hope I'm saying that correctly. So if that's the case, it seems to me, and given the fact that Steve Wolf has identified me on that action part of the three-part strategic communication framework he laid out this morning. It seems to me that those 7, or whichever 7 there are good anchor points for the interface between care delivery, healthcare, and education in the form of local school districts. And so I'm particularly curious, and I did ask him this as well, about the methodology for determining those. And it seems to me that that would be a fairly important thing to be made explicit, and that many school districts and healthcare organizations across the country might use to set common priorities or points of interface. And Norris, you in your comments touched on several of the ones on his list. So I suspect there's a lot of commonality across all those. But I just welcome your comments on that sort of notion of a list of priorities that might bring together both education and healthcare.
I'll just say a word. I mean, the Department of Education, we don't specify, and that's why I just mentioned the framework of engagement to a large degree. This is a state and local matter. I reference those as examples because they showed up in so many presentations of key health conditions affecting health. So I just used some examples. So it was in no way meant to say, this should be the priority list of what we screen for. Of course, HHS and Ed in our recent 0 to 5 Watch Me Thrive was trying to fill a gap because vision screening is quite ubiquitous. Someone referenced that. I don't have the data on that. Not all states require it. But in the 0 to 5 Help Me Thrive, we were trying to fill a gap with some resources in developmental screenings, which we found, was one area that we felt people should take a greater look at and could use some resources on. So, but it's a good question about, what is the priority list?
I'll see if I can answer this in my own way. So I guess one is, whatever the list is, it's a list of individual problems that a child might have. I think in every list, I would like to see families at the top, and some kind of something about engaging families and understanding the family perspective. I mean, if we're going to make change in the long run, it's going to be in part, at least, through the parents and through the family. The second thing I wanted to say is that and I didn't really get to describe the very complex sort of systems approach that we're taking and trying to integrate these different components. I think at a school level, we're thinking about three things. One is policies, and that has to obviously come from the principal, and then two, practices, and that we're thinking about that at the classroom level and what really takes place in the classroom, which for us is health and education all combined. And then the third is a program, an evidence-based program for families. And I think that family engagement is now a big buzzword in education, and I think people are paying attention to families at that level. But what they mean by family engagement can often mean, sending a flyer home to parents, or translating. Maybe if you're culturally informed, you're translating something into the language that the parent actually speaks. But that's not going to lead to any behavior change. And so I think if we really want to influence children's trajectories for health as well as education, we have to get much more serious about really appreciating the complexities of what it means to change an environment at home and in the classroom and in school.
Okay. Again, thank you. This is great stuff. This is probably more of a comment or a thought than a question, but I think it's a question for us. Maybe I even thought about saving it till the end of the day, but let me just try this. So you've heard the term a lot of health in all policies. We use that term, and we had a whole workshop on it in September. And actually, there's some criticism of that term as being too kind of health-centric, like when we social policy is health policy, you begin to frame everything from a health or healthcare perspective, which is a trap. However, we are in search of, like the title of this day, places where we can work together, where there really is our co-benefits, from collaboration. But I guess the question I want to sharpen, actually, I think the question that Holly started with, or maybe this is the thought. So I'm wondering, would we categorize the opportunities for collaboration in either collaboration between, say, healthcare and public health and the education sector, or whatever, however conceptualized? So is it either stay out of the way because we're doing fine on our own and you might just mess it up if you got involved? That's one. Or where, as Norris, you suggested, maybe there's policy clout to be added to policies or investments that need in the education sector that need support on their own, but for which it's heavy lifting, so other voices may be helpful. So that would be a second. Or a third, where there's actually program co-involvement, where about some of the programs we've heard. So I guess the thought is that to us, maybe to the roundtable, is that a useful way of thinking about it, not only for education, but for the other sectors that we will be talking about and working with? And if I want to ask a question, if any of you have any ideas about whether things that you've thought about, whether that's a useful way of thinking about it, or whether you have any ideas about what falls into each of those categories. I hope that's clear. We'll hold that later. Hang on.
Other questions? Oh, I'm sorry. All right, go ahead, Mary.
Again, thank you for your presentations. There were two things that I didn't hear that I wondered if you could comment on. One, in the screening or key health conditions, particularly affecting young people, there was no mention of dental. And we know that dental sealants are very effective in preventing dental caries, and it's so intertwined with kids, having pain in their mouth and not being able to eat, and nutrition. So I just wondered, why are we not raising that particular issue? And a second is, schools ending, summertime kids lose a lot of the progress that they've made if they don't have some sort of activity to kind of keep them engaged in some manner academically. But also it's a time for kids who have free lunch, free breakfast, that they don't have the same kind of nutrition. And we've seen some, great programs in California with summer meals programs that have been tied to educational programs using the library as the basis for working across, education and public health and nutrition. I wondered if you could address both, what should we be doing and might we be able to do together with summertime programs, and why dental doesn't show up.
I don't want to speak to the dental. I mean, many people make the case, and there's a long list. I did want to just address the mills, the summer mills, because the Department of Agriculture does have a program to promote summer mills so that there is not that deficit. And I know we participated in an effort to really solicit partners to help make that happen. So I know they're always seeking people to be engaged in that program. And, as to the summer and the cognitive retrenchment, if you will, that might happen, it's an issue that many school districts tackle with summer programs and efforts to communicate to parents the importance of reading in the summer. And some school districts even require summer reading, although that's a difficult thing to get kids to do. But they're all important issues, and different districts tackle them in different ways. And the federal government does have a major program on summer meals for those who rely on the federally reduced and free lunch program during the year.
On the dental question, I don't think we would have any opposition to that. I just think in terms of what educators are thinking about, they don't think about that first when they think about health. I mean, if you remember my survey slide, they see a real connection between achievement and other health issues, which maybe they need help seeing that for dental issues. For me, I come from a social marketing and communications background. When I have a limited amount of resources to convince somebody to do anything about the health status and the health situation in schools, if I can find something that they're already concerned about and work with them on that, and I can make a difference on that, that's where I'm going to focus my resources. So, maybe I need to be educated on why dental concerns me, but that is the reason why it's not a focus of ours. Again, on the feeding program, student hunger is a big concern. And spontaneously, in partnership with local food banks, educators all over the country are doing things like weekend backpack programs where they stuff the kids' backpack full of canned non-perishable food so they have something to eat over the weekend, and trying to figure out those gaps that we have on the weekends, that we have during the summer, at night, and how to fill those up. They get complicated in the practical because something like a school breakfast or a lunch program, the logistics of that are a lot simpler. But when you get into these other areas where kids aren't normally congregating during the summer anyway, you have to find out where they are and figure out how you make the food program work there, and how does the reimbursement work and all that stuff. It can be done, and we're actually working on trying to figure that out.
Can I take the liberty of going back to David's question? Because I think I would like to try to answer it. One is I do want to say that certainly we shouldn't stick with the status quo. I think everyone would agree that neither systems are necessarily working. And the one point I wanted to make is that I think teachers are people too, and it's sort of a unique way of thinking about health in a school system. But I was sort of struck by, Jim, your survey, and I think it was the second concern about teachers was stress. And there's some really interesting work coming from Mark Greenberg in New York City showing that mindfulness training for teachers actually improves their physical health in terms of blood pressure and other things. And I think that there's real potential for integration there in thinking about supporting teachers, which obviously will have an effect on the kids that they're teaching, but will also have an effect on their own health outcomes.
One of the things that the roundtable is looking at is sustainability, and Terry and I chair the resources driver group, and a piece of that is financial sustainability. Can Jim and Lori talk about what you're thinking about in terms of financial sustainability in two ways? One, your current set of programs, but secondly, if you want to spread and scale, which it seems like you do want to, what are you thinking about the model for that?
Well, the most sustainable program we have right now is the breakfast program, and thanks to the USDA regulation, it's easy to make that sustainable because once you do the initial sort of startup costs and training of it, it pays for itself through increased reimbursements. Would that a lot of our health programs would work that way? I think the way we look at it is if you take the time to fit it into local priorities and customize it to the needs of the school district and the people who are working there, and if you make the value proposition positive, then it will be sustainable. So for us, it's that engagement piece, that customization piece that's so important.
But when you have your breakfast in the classroom program, right? There's a cost to putting that program together. So I'm trying to understand how what's your model for paying for that? I mean, right now you have grants. It seems like you have foundations and grants, but I'm also assuming that as a disseminator, your organization seems like it's a disseminator for the NEA. You probably have some seed money from NEA, and then you're using that to get additional grants to further these programs. But is there more to that in terms of how you're thinking about spreading and scaling, like your breakfast in the classroom program, as an example?
We have seen that.
Yeah,
so in several states, we've seen that where breakfast has been successful on a pilot basis, that the state legislature stepped in and funded it for not the whole state, but the high-need districts.
Yeah.
So we have seen it happen. I mean,
and are you intentional about that? Because it sounded like you weren't. It sounded like you said, oh, you couldn't quite take credit for the Colorado.
Well, I have to be careful about being intentional about it because I'm a 501c3 organization.
Yeah.
But I work with my peers across the hall who work in a union and try to be intentional through them as much as possible.
Right.
So yes, we are very strong advocates for child health where we can be. Mm-hmm. Yeah, it wasn't part of the program plan, but it was a nice outcome of it. And compared, there is support we have seen support in certain states and in certain districts for additional investments in education and health issues as they relate to schools. Yeah. But you just need to make the case very real, very obvious, and very connected to the top priorities of schools and districts.
Mm-hmm. And Lori?
Yeah, so let me talk about our sort of history and our current situation, and then where we're hoping to go. So most of our work has been funded through federal grants, both from the Institute for Education Sciences and the National Institute of Health, mental health. We've been funded, we've received a lot of significant and critical support from philanthropy. So any innovation that we've done, any of the careful work that we've done has not been funded from the federal government. And our research trials, it's been funded from philanthropy, which has allowed us to, develop best practices. In the last couple of years, we've been funded by the New York State Office of Mental Health, who has seen the value of preventive intervention, and they are making a commitment for the next 4 years to put us as a line item in the state budget, which was a big win for us. On the ground, we've been working at a very close level with our schools and principals, and trying to figure out the mystery to how they're funded and what their little buckets of money are, and how they're spending it on programs that have no evidence base, and how they can use those small pots of money for family engagement, for meals, because part of our program that's expensive is providing dinner for the families. So how to repurpose the funds. And so that's sort of our current state. It's a mishmash of lots of different ways to go. We are just this month starting a strategic planning process that's supported by philanthropy, so that we can have a business model for scale up. We're mostly focused right now on New York City and trying to think about how to scale in New York City, which is no small feat, as they are undergoing pre-K expansion. And I think there's lots of great opportunities there, but also to think about a model for national scaling, which would, for us, certainly our focus is on schools, which is very hard for scaling nationally. Also, we've been working in community-based organizations and in Head Start programs, which has some easier platform for dissemination. And then I also think there are some unique opportunities through things like Promise Neighborhood initiatives and other initiatives that are really, focused on the kind of environments that we want to be working in urban environments. So all of our trial work has been in public schools with Universal Pre-K, and then the work to move into community-based organizations with Head Start has been a pretty big undertaking. So the kids are the same age, but the systems differences and the workforce differences and the population that they serve are things that we're trying to be very thoughtful about, because if we move too quickly into different systems and with different people, we're going to lose all of the effects. We're sure about that. So we've been pretty careful about that. I think we have a niche in this age group, and also potentially in the setting. I think our school work is, I don't know any other people in the country that are working in urban schools in the pre-K environment and thinking about not only teachers and the pre-K students, but families, and then the principal piece. So for now, we're sticking with the age and a center-based, an education center. So whether it's UPK or Head Start, which again are very different systems for us, that's what we're choosing to focus on right now. But I do think that there are incredible opportunities, maybe not for us, but for other people doing similar kind of work in daycare settings, in primary care practices, in other community settings. Our NYU Langone Medical Center has a beautiful, give a plug, community service plan, and we are part of that community service plan. I think we're one of the central programs of that, and so we'll be looking to other systems like federally qualified healthcare, which also is part of the community service plan, to possibly have this kind of interaction with.
Thank you, Lori.
I'd just like to mention one thing related to the sustainability, because Lori did a very good job about talking about the impacts of trauma, what we know from ACEs study, and dysregulation. and parents as the intervention points. One thing I didn't mention that I have to mention really quickly is one of our major new investments in fiscal year 14 is something called School Climate Transformation Grants, where we are providing substantial resources to school districts across the country and states to improve their capacity to put in place multi-tiered behavioral frameworks to really get into the behavioral health space. And, you know, I appreciate you talking about the research on that, and we've learned a great deal about the impacts of trauma and impacts on behavior and how we have to intervene. So you're doing it at the parent level. We're going to really try to bolster the capacity of schools across the country in that space.
Thank you, Norris. I think we have time for one more question from Terry, and then we'll move on to the next session.
Thank you for your presentation. It actually, I had a question for Jim, and Norris, you sort of ended at this. So some experiences we're having locally in the greater Cleveland area is that sustaining wellness policies in the committee to support the wellness policy can be a time challenge in the school environment. And so we're trying to be supportive in that context. But one of the things that's interesting, we're hearing there may be time challenges within the school that are obvious related to ramping up to apply for dollars at times and asking for external assistance from nonprofits, public health, governmental public health, and others to help schools to put together applications for different funding sources. So I wonder, Jim, if you have any experience with that, whether that's been a way that might support some sustainability implications or spread and scale.
So your question is, do we have experience with people, with school districts complaining they don't want to fill out the application for grant funding, or supporting them in doing that?
Yes, and yes.
Yeah. Every single sub-grant program we have, they're always asking about that because most people in the school environment are not grant writers, and it's outside of their expertise area, and they may have a great program, they just don't know how to express it, and not meant to mention that they don't have the energy to just put it together with everything else they're doing. The organization does not have specific experience in helping with applications. We try to narrow the applicant pool before they do the application because you reduce the frustration that way. So the next round of funding we're doing for our breakfast program, next Thursday we're having a breakfast summit in Richmond. No, not Richmond, Norfolk, Virginia, because Virginia is our next one of our next states. So we've worked with the state affiliate to find a selection of locals that meet the profile that we think leads to success, and we've done a little interviewing with them ahead of time to get a feel for how they would like the program. We're going to bring them all together to talk more about the program, get them motivated, and then they go and do the application. So there's going to be a much higher success rate. So I guess our solution to the problem is try to reduce the number of rejections and frustration, because it does hurt the program in the long term. That's helpful.
All right, well, that wraps it up. Let's give our panelists a round of applause. Thank you all very much for a wonderful presentation and dialogue.